Neil, sorry to
With cervical
interrupt you again, but could you please try changing your location? Because
8.2% this estimate. Why does this happen? The screening uptake is as low as 22 to 36%. Low screening is attributed mainly due to poor Bathinda on 17th March 2021. Is everybody able to hear now? Is it audible at the moment?
No, I think there's a very big network problem. Could you try moving like your work space or
I have
something?
changed my location. Now is it
Yeah,
audible?
this is now it's better. Now the slideshow is also moving. Please continue. Thank you.
Thank you. A community-based cross-sectional study was conducted between April and September 2021. The study was ethically approved by the Institutional Ethics Committee of the All India Institute of Medical Sciences on 17th March 2021. Inclusion criteria included ambulatory women between 18 to 65 years old. Exclusion criteria included pregnant postpartum women or those with a history of hysterectomy, previous history of cervical cancer, previous history of uterine prolapse, and significant psychological and psychiatric illnesses. Methods. The study was conducted in 3 districts of Punjab. Now, why did we choose Punjab? Because Punjab has a high incidence rate and mortality of cervical cancer. It ranks about 11th in the country. There is a lack of screening. As per reports of the NFHS 5, only 2.4% of women had undergone a screening test for cervical cancer. Punjab was also among the first states in the country to initiate HPV vaccination on a pilot basis, showing its dedication to controlling the disease. Sample size. Considering the awareness regarding the prevention of cervical cancer among women as 63.2%, with 80% power, alpha of 0.05, and absolute error of 5%, a design effect of 1.5, and a non-response of 10, 600 women were recruited. The sampling technique was multi-stage random sampling or clustered sampling, where in the first stage, a community health center was randomly chosen from each district. That was 3 community health centers were chosen. Then 2 primary health centers and 2 health and wellness centers, 6 primary health centers and 6 health and wellness centers was chosen. And from the third stage, randomly 50 women were selected from each health and wellness center, compiled using the eligible couple registers. The eligible women were briefed regarding the study objective, and written informed consent was obtained. The data was conducted using a pre-tested semi-structured questionnaire prepared using an extensive literature review, the variables of which I'll be describing later. The validity of the questionnaire was determined by 3 experts not involved in the study. This questionnaire involved background characteristics, awareness about cervical cancer, the HPV vaccine, willingness for screening, and acceptance. A pilot study was done on 25 patients, and the interviews were conducted by trained field investigators who were adequately trained and sensitized about the topic, and were aware of the referral process in case there was a need to ensure a continuum of care. The data was analyzed using the Statistical Package for Social Sciences, SPSS version 21. The test of significance was performed using the chi-square test to determine the association between 2 primary dependent variables, whether the women had ever heard of cervical cancer or ever heard of HPV vaccine, and socio-demographic characteristics taken as independent variables. A p-value of 0.05, less than 0.05, was considered statistically significant. The results were depicted later using frequency and percentages. So now this is the study variables which I'll be showing. This is the first dependent variable which shows awareness about cervical cancer. If a woman is fully aware, a score of 5 was given, partially aware 1 to 4, unaware 0.
Yeah, sorry to interrupt you, but your slideshow is not moving.
Yeah, because I'm describing this particular part.
No, it's stuck on the method slide.
Okay.
Yeah, could you like stop?
Now?
Now it's moving, yes.
Okay, I'll present like this then. Mode of transmission was sexual. Symptoms of cervical cancer were as abnormal menstrual. Sorry. Mode of transmission is sexual. Symptoms of cervical cancer as abnormal menstrual or vaginal bleeding. Preventive measures against cervical cancer like avoiding early marriage or HPV vaccination or quitting smoking or avoiding multiple sexual partners. Risk factors: including early marriage, early pregnancy, repeated pregnancy, oral intake of OC pills, etc. And whether they were aware of the methods of diagnosis such as visual inspection with low iodine and visual inspection with acetic acid. Awareness about HPV vaccine was again assessed, as fully aware was given a score of 4, partially aware was 1 to 3, and unaware was 0. The variables assessed were whether there was a vaccine, whether they were aware that there was a vaccine for cervical cancer, whether they were aware that there was eligibility for vaccination as adolescent girls, whether they were aware about the name of the vaccine, or whether they knew the vaccine schedule. And the independent variables included age groups, marital status, level of education, occupation, number of children, number of sexual partners, whether there was any history of sexually transmitted diseases or treatment, or history of any cervical cancer in the family. So, in the age groups, the characteristics were the characteristics which were found were 18 to 25 years, 25 to 35 years, 35 to 45, and 45 to 65 years. Marital status, whether the woman was single, never married, married or separated, or a widow. Level of education, whether they were illiterate up to primary, up to high school or graduate. Number of children, whether they were having 0, 1, 2, 3 or more. Whether they were a student, homemaker or working, or whether they had no sexual partners, a single sexual partner or multiple partners. Out now the results of the demographic
Niya,
distribution, which was an
sorry to
independent
disturb-
variable.
Hello, sorry to disturb you again, but the slideshow is stuck again. Yeah.
Now is it visible?
Yes.
Why
Of the
don't you
total
display-
600
why-
participants in the analysis,
Dr. Niya, why don't you display it as a slideshow, as a just enlarge the entire slide rather than in a form of notes? There's a small.
yes, ma'am, I have done that. I've enlarged it.
uh,
Is it
okay.
visible, ma'am? Is it enlarged? I've been enlarged.
No, it is enlarged, but this is not the slideshow. This is just the here's the slides in the form of notes that we are seeing. For
But
slide,
ma'am,
you have
I
to
put
press.
it as a slideshow. I've enlarged it from current slide. I
No,
don't
you
know why
have
is it
to
not being
start
seen.
you have to press start the slideshow from current slide.
Yes,
There's
ma'am, I've done the exact thing.
okay,
Is it
still
visible now?
there. Okay, they are still showing this way. Fine, fine. Continue, please.
Of the total 600 participants in the analysis, majority were in the age group of 20 to 45 years, 79% were married, and 76% had a single sexual partner. Out of about 64% of the participants were graduates, 64% were homemakers, and 60% had 1 or 2 children. About 3.5% had a history of STDs, and among them, nearly half had taken treatment for STDs. About 12% had a history of cancer in the family. So, this is the distribution of female participants with comprehensive awareness about the dependent variables, such as awareness of cervical cancer and awareness of HPV vaccine from the 3 districts of Punjab. So, here, 90% of the participants had heard of cervical cancer, but only 1.8% had comprehensive knowledge of the symptoms. That is, use of a pad or tampon, 66% were aware. Use of cloth during menses, 45.6% were aware that this is a risk factor. And multiple sex partners, unfortunately, 25.4% of women only were aware. Now, symptom awareness in women suffering from cervical cancer. Abnormal uterine bleeding, 99.6% women were aware. About pelvic pain, only 41.7% were aware. And urination, 25.2% were aware, as shown in the table. In this pie chart, we can see that
Niya, your slide is
55
not moving.
Okay, 1 minute. I put it as a slideshow. I do not know why it's not coming. There's a full screen view.
Could you please just manually also ensure that the slide is moving along with the slideshow?
Yeah, so I'll do that.
It's okay. It's working fine now. Thank you.
55% of rural women in Punjab were not ready for screening. 94.7% of rural women with Punjab were unvaccinated with HPV vaccine. Very few participants were vaccinated with the HPV vaccine. Out of the categorization of awareness, 94.3% of the women were unaware. 0.2% women were fully aware, and 5.5% of women were partially aware. Among the non-vaccinated group, the reasons for not getting the vaccination were lack of knowledge, most commonly, followed by cost, expensive, social stigma, post-vaccination complications, and some for no reason. So the discussion is, despite awareness of cervical cancer among women being 90%, only 1.8% rural women in Punjab have comprehensive knowledge. This highlights a critical knowledge gap. Awareness is extremely low, primarily due to lack of knowledge, high vaccine costs, social stigma, and fear of side effects. Social cultural taboos and misconceptions also hindered willingness significantly. Awareness and preventive practices were not associated with socio-demographic factors, and most women relied on family, friends, and community health workers for information. And there was a urban-rural divide because there was low awareness in rural areas, but there was high awareness in urban areas because of health literacy and access to facilities. So the importance of screening is screening helps in reduction of the disease burden by 60 to 90%. A single visit approach encourages more women to get screened, and outreach sessions, community mobilizations are the need of the hour, and training healthcare workers also can improve communication. A step towards WHO cancer elimination goals, the launch of the indigenous HPV vaccine Cervavac in India's universal immunization program will offer a promising path to meet WHO's 2030 cervical cancer elimination goals. The
Niya, could you
conclusion
please
is,
ensure your slides are moving?
are they moving now?
Yes, thank you.
Conclusions, lack of comprehensive awareness. There is a limited knowledge about cervical cancer among rural women in Punjab. There is very low awareness and uptake about the HPV vaccine. The barriers include socio-cultural taboos, misinformation, and cost. The information sources are not limited to literacy is also a barrier because only family, friends, and community health workers are the main information sources. Mass media has minimal impact. Recommendation, there is a need for large-scale, culturally sensitive health advocacy programs to promote regular screening and prepare for indigenous HPV vaccine inclusion in universal immunization program, which is a secondary prevention method, and coordinated efforts essential to meet WHO's 2030 cervical cancer goal. Thank you, and thank you for getting me present.
Thank you so much, Niya, for the presentation.
Welcome, ma'am. It was an honor to present here.
Ma'am, we would love to hear your inputs about the paper presented, and we also would like to ask our questions. So, Niya, Niya, we couldn't really see your presentation when you were presenting. Could you please keep the screen shared and
Yes.
so that ma'am could refer to the slides as well?
Yes, I'll do
Thank
that.
you.
Oh, give me a minute. Can it be seen now? Can you guys see it now?
Yes, it's on the thank you slide.
Yeah. I'm
So
putting
a
it on
very
slide.
good evening to everyone.
Evening.
Okay, so this is a very pertinent and an important topic that Dr. Nia has chosen to present, and I'm really glad that you've chosen this topic to present. Your slides have been wonderful, but unfortunately, initially there was a discrepancy in your voice also, and the slideshow. I'm a little confused still why the slideshows are not running. Um, uh, Still, you have captured the slides very. You have done a very crisp presentation, which is good. It's not a very lengthy. It's not a very lengthy slide that you have presented. And a very important point that you've brought up is the unawareness. The unawareness is in the not just in rural area. We being in Delhi, we are currently working and seeing patients in Maulana Azad Medical Institute. There are a lot many times that the patients come up and they're completely unaware of these situations. They may be knowing what the cervical cancer is, as in your study, that people know what is cervical cancer, but a comprehensive knowledge is very limited.
Thank you, ma'am.
Um,
Okay,
Ma'am,
so Monica Gupta is asking that she wanted some light on see and treat approach and see triage and treat approach. So do we have a slide for that see and treat? If you have made a slide on that, what were they mentioning about? I think that is fine. So see and treat is worthy in Indian in the developing nations where first and foremost you need to understand why would we like to do see and treat, where we anticipate that the patients are not going to come again. There are many patients who come from distant houses and the ladies are working in the house and they have a lot of responsibilities of the house, so they keep ignoring their symptoms, also they keep ignoring themselves. So it is very rare for them to one fine day they will come to the hospital to just ask for some random complaints, random assessment. So we have a lot of patients who just complain of backache and lower abdominal pain. These are the only symptoms they come for. They don't have any specific cervical cancer symptoms. So this see and treat approach is for these patients whom you don't know whether they will come again or not. So in these cases, what we do majorly is when we examine the lady in a per speculum examination, we are going to see the cervix either via naked eye or via a colposcope, or during the examination we do via an villi, that is visualization after acetic acid and Lugol's iodine, respectively. In all these cases, if there is any suspiciousness on the naked eye, then we can move ahead with the colposcope. If we have any doubt or with respect to the complaints of the patient having persistent white discharge, and then while examining, we find some significant findings, we just go ahead with acetic acid and Lugol's iodine step by step application. If we find any suspicious areas, instead of taking the biopsy of those suspicious areas and following up the patient with the report of that biopsy, we just directly treat that lesion, suspicious lesion, with either ablative procedures such as cold procedures such as cryotherapy, or burn procedures such as we can either burn it with char it with the there are techniques where we can use the laser depending on whatever is available. So these are all portable methods that you can take in PHCs and can set up 1 month camps or maybe a week's camp and examine all the patients with a cryotherapy gun. It just needs a liquid nitrogen cylinder. Nothing much of a setup is needed. So everything can be arranged, and then you just see and treat because you know that the patient, you doubt that the patient is going to come again. So this is only on the suspiciousness of the examination findings and visualization after acetic acid and Lugol's iodine. I hope I was clear, and if you have any further doubts, you can please ask again.
ma'am, I have a question. Um, in women who are aware of cervical cancer but still do not want to participate in screening, what are the main barriers that you have observed?
So, as you have seen, sometimes the patients are uncomfortable in getting themselves examined. The one of the major because in government setup you can see there is a lot of load, and you might, even in your setups, in different setups, you might see the clinician practicing it at a very fast pace and not being able to provide individual patient a substantial amount of time, which you could see in a private setup, which increases the anxiety of the patient furthermore. Plus the entire process of getting showing the private parts in front may not be comfortable with even educated women right away. So it definitely gives a sense of embarrassment, a sense of social embarrassment, and even educated women do think, why would I be the target of a cervical cancer? So many women think that I have a single partner, I have not have any malpractices, like I'm not smoking, I'm not doing this, I'm not doing that. So my risk factors are extremely low. Why would I be the target of a cervical cancer? So these all multifactorial causes make people think, okay, fine, why should I get it done? Furthermore, it is not, for example, tuberculosis, thalassemia, these are such, there are huge national programs for these. Like the kind of awareness programs that are running for tuberculosis with a political intent to curb it. So that is not yet reached with cervical cancer yet.
All right, ma'am. Do we have other questions? I would like to know that from a health policy perspective, what do you think is the most cost-effective intervention? Is it screening? Is it vaccination? Or is it something else?
I think in the long run, it initially might assume cost expensive, but in the long run, the most cost effective method would be implementing the vaccination and national immunization schedule at school level, whether it is government or private school, to 9 to 11-year-old females, and maybe in the future, even boys of 9 to 11-year-old, because it will take at least 2 generations to get that herd immunity. If a female who is getting the vaccination done at 10 years, assume that when she turns out to be between 40 to 45, then she will get the effectiveness. Okay, now she does not have anything, she will be relaxed after 40 years. So fine, I have that effectiveness of the vaccine. And between 40, because considering late marriages and so many other factors, her next generation will also have the same immunity from 9 years to 14 years. And then there is, once the cycle goes on, then is what we call as the herd immunity develops. For example, the female, despite having multiple sexual partners, such as in sexual workers, sex workers, they will not be able to have the infections from the male partner also, if the male partner has a sexually transmitted disease. So that is the kind of future target one should have. Hopefully, in the near future, the after there is a political intent, the vaccination enters the national immunization schedule, because now in 9 to 11 only 2 vaccines are to be implemented. Only 2 vaccine doses are to be given, 0 and 6 months. So I think that should be the best shot in the long run.
Thank you so much, ma'am. Ma'am, another question that we received was, can self-sampling HPV tests reliably replace clinic-based screening in rural women?
Definitely, if the person is understanding and educated, there are very high chances that self-sampling can also help, because there's so many girls who are able to insert, and so many females who are able to understand the anatomy and do the test themselves. But if there is a lack of understanding and lack of how to do the procedure, understanding how to do the procedure, then it is not worthwhile in utilizing the same in those ladies.
Thank you, ma'am. Ma'am, another question that we got was, what protocols should be followed for post-treatment surveillance, and how compliant are patients in like rural settings versus in urban settings, and how can we improve the compliance of the patients?
So there are many patients who come from small villages, distant from maybe from UP, Odisha, Bihar. Odisha is a very self-reliant state, वैसे, by the way. The patients usually that Delhi caters to is the Uttar Pradesh, Delhi itself, and Bihar population. This is the belt that the entire our college, Maulana Azad Medical College, is currently serving to, because Delhi is majorly comprised of the population from these three states. So once the patient is diagnosed with certain lesion which can probably convert to cervical cancer in the near future, once that is diagnosed, majority of the women do understand. You have to explain it with their relative, not solely. The majority of the patient and relatives do understand the gravity of the situation, and they come for constant follow up. But there are certain people, because of resources, because of home responsibilities, that they do, and that they do not care, matlab that they're not able to take care of themselves with such intensity. You might find 5 to 10% of the population who will still ignore their symptoms and not be able to come. And then finally, one fine day, when they have the full blown cervical cancer with symptoms and maybe even complications, they may report to you again. So there will always be 5 to 10% population who will ignore their minor symptoms.
Yes, ma'am. Thank you so much for that answer. Ma'am, another question was that which screening method, pap smear, VIA, or HPV DNA testing, is the most feasible in rural population given the cultural norms and all that?
I think VIA and VILI, that is the most feasible. The problem with the pap smear and the liquid-based cytology is it will still take some time to report it. Like even in the best of the best setups, it will take at least 4 to 5 days to have a report. And once there is a huge quantity, like in our setup, there is huge quantity, like there are running samples of around 100 per day. With such a 100 to 200 per day, they are running pap smear, liquid based cytologies. So with samples running in huge numbers, you cannot anticipate the report immediately. So you get the report maybe even after 1 month. That doesn't justify in a low resource setting. That is why I think see and treat is just the right approach there.
Thank you so much, ma'am.
Mhm.
Ma'am, one last question from my side was, should cervical screening be bundled with other antenatal immunization or family planning visits to increase the uptake in rural women?
Sorry, I misconstrued your question. Can you repeat it?
Ma'am, should cervical screening be bundled with other reproductive health services like antenatal screening, immunization, family planning visits to increase awareness in rural women?
I think cervical cancer in its own way is a huge topic to explain. Bundling it up is just going to confuse the patients and is going to overload a camp area where the awareness is going to take place. So unnecessary. I think it should be independent. Like breast cancer has to be independent. Things cannot be confused. Usually what happens, the similar things are bundled up. Like breast cancer usually is bundled up at, since it is found at the age of 40, 50, it is bundled up usually with vitamin D3 testing or body mass index testing or maybe the bone density testing. These kind of testings are mixed up so that there is no confusion between two gynecological problems within a lady.
Thank you, ma'am. Ma'am, another question we had was in cases where, say, a rural woman tests positive on screening, but she cannot access colposcopy or other biopsy facilities. So, what should be like the next best management protocol in that case?
See and treat. Once you treat, then she is advised. Treatment is that you're given her the treatment. Then she needs a further follow up either yearly or maybe 6 monthly or yearly, depending upon the lesion that we had actually triaged. If it is a significant lesion which you have treated, then you would like to call her maybe even 3 to 6 monthly. If there was a minor lesion, you might call her to visit your clinic maybe after 1 year, and to get a basic pap smear or a liquid based cytology repeated again, something of that sort.
All right, ma'am. Ma'am, this is the final question from my side, and it's that what innovations or emerging technologies do you think will most impact the cervical cancer prevention in India in the next 5 or 10 years?
I think they're working on the vaccinations itself. They have introduced the nonavalent Gardasil vaccine, which is trying to cover the each and every the vaginal warts, the vulval warts, cervical cancer. It's practically covering everything, and Gardasil is for both boys and girls, and it is also covering up the anal warts. So even minor chances of having any kind of lesion which can possibly in the future, let's say 10, 20 years in the future, is going to convert to cervical cancer, that it is targeting that. So I think best is the improvisation in the vaccination techniques. Maybe in the near future we can get some pathological ways to test, like liquid based cytology. Maybe we can find different ways to assess. We may be able to incorporate AI to read through the cytopathology slides, and may be able to scan through and run through to get the reports ASAP. Like we are getting at least 4 days to make the slide, maintain the slide, and get the reports for liquid based cytology or pap smear. Maybe we can incorporate AI and get these things done at an earlier stage.
Thank you so much for answering the questions, ma'am. Does
Mhm.
anyone have any other
I
question?
think two questions they have mentioned. One is by Dr. Lekha, that what do you think is the best way to disseminate the information about both HPV vaccine and cervical cancer screening in community? I think it is in public areas where there are people in huge groups. They can like railway stations, like hospital setups, like schools. You can have television and audiovisual aids which can continuously keep on rotating videos about this thing. Railway stations, these are major areas where you can have all kinds of people running from all strata. Airports, you can have all people running from lower middle class to upper middle class. They can all get awareness. Even men do need to have the awareness of the same. So I think that is one way to have a continuous audio visual aids. And the second question that one has mentioned, or Nia has mentioned, is would adding HPV vaccine to UIP improve awareness in rural areas? Particularly if it is added in a national immunization program, then obviously it will enter the simple government schools as well, where majority of the girls are studying from all strata of the society. So I am pretty sure that should be the ultimate aim of the government, to be able to curb cervical cancer. I think we're done with all the questions.
Yes, ma'am. I think Nia also asked a question about the universal immunization program and how it can help improve awareness in rural areas and LMICs.
Yes, for the same, I mentioned that it is probably going to explain once it is included in the UIP, it is going to basically incorporate into the government schools also. And once it is included in the government school, the girls will be automatically forced to ask, why is this, what is this injection for, and the parents are going to inquire about it. They will automatically get their answers that this is for a cervical cancer and this will prevent a viral infection. They're already taking so many vaccines. One vaccine, if it is included in the universal immunization program, it is not going to probably make them worried about the vaccination. Everybody got the COVID vaccine also. Even in rural areas, every person came to know about COVID. So it was made mandatory for each and every person. So any vaccine, once it becomes mandatory for the girl child between 9 to 11, it will automatically improve the awareness, whether in rural or urban areas.
Thank you, ma'am.
Hmm. Thank you. I think it was a wonderful topic of discussion. And I think this SIMSOG, I was not aware of this unless you had approached me. I think you guys are doing a great work in making, spreading the interest as well. So great work, great job.
Thank you so much, ma'am. Ma'am, on behalf of SIMSOG, I would like to extend my heartfelt gratitude and sincere thanks for guiding the discussion with such insight and clarity. Your expertise has added immense value to our understanding of cervical cancer screening and prevention strategies. And thank you to Niya for presenting today and for all the participants for your active engagement and contributions. We would send a post event questionnaire in the chat box, and for certificates and for ensuring your attendance, you could please just fill it up. Um, and once again, thank you so much, ma'am, for moderating today's session. This wouldn't have been as insightful without you. Thank you.
Thank you so much. Thank you. Okay, take care.